we just thought that for a kind of kick-off meeting, we would just do a very kind of generalized talk and try and sort of put together some thoughts about being a CCIO and what it means. I mean, obviously, I'm in a secondary and tertiary organisation, so I have a specific remit. So this is obviously coming from my point of view. And as I say, it's pretty eclectic. I'm going to jump around quite a lot in this. I think each of the topics that I'm covering could be a talk in their own right. Anyway, we'll see what you think of it, and I can always expand on some other things in later meetings if people are interested. Okay, Kev. So what I'm going to try and cover is, what's a CCIO for in the first place? What about my organisation? We've just done a big system rollout that people might be interested in and maybe could be helpful across other organisations. I'm very interested in usability of systems. That's my big kind of interest. So I'll talk a little bit about that. The usability sort of goes on to, you know, can you change, for example, doctors' behaviour? We've done quite a lot of work about doctors, nurses, pharmacists, and so on. I haven't got time to go into it all, but I'll just give you one example of doctor behaviour change in this little talk. Then just right at the end, I just want to say a couple of things about the CCIO within the whole system, and then the CCIO's responsibility about guarding the health of future generations as well. Thanks, Kev. All right, so what is a CCIO for? Well, I think it completely depends on the organisation that you're working for, actually. But definitely for my role, I see it as being a conduit or an interpreter a lot of the time between clinical staff and technical and digital staff, suppliers, managers, and so on. I think that one of my responsibilities is to safeguard good clinical care when we employ digital systems and in digital systems in general. I think another part of my role is to use the power of the data that we're producing off these systems for use now in safeguarding clinical care for people in the NHS. And then I also think that my role is to safeguard future generations by making sure that the data is available and being used in research. There's some other things that CCIOs do. A lot of CCIOs do, and I do a lot, is manage teams of people, decide on which systems we're trying to buy and implement, facilitate wider data research, ensure privacy and fairness about the systems, the data, and the people that are being looked after, safeguarding patients. And then also, you know, I think that lots of CCIOs, including myself, are the digital lead, clinical lead for many different systems. Thanks, Kev. So one thing I thought might be very helpful to share is that we've just written a digital strategy for UHB, and it runs to about 20 pages, the strategy, but the principles of the strategy I just put up here. And once the strategy is sort of agreed, then I'm very happy to widely share this. But this sort of, I think, encompasses really what my role is within UHB. So we want to standardize clinical systems to support workflows so that we don't have lots of different ways of working across all the different parts of the organization. We want to increase clinical user adoption and improve the clinician experience in using these digital systems. We want to enhance our anchor EPR to include paediatrics, obstetrics, and anaesthetics. That's a specific thing for UHB because we've just merged the trusts, and now we have paediatrics and obstetrics within the trust, which we didn't have before. We have a sort of partly built anaesthetic module, and it's not wholly built yet, so we want to enhance that. We obviously want to support any emerging technologies and integrate those. We're very minded about our patient portal, which we've got an excellent patient portal, which I'd like to talk about in a future meeting. But I'm very interested now in the idea of a single digital front door with the advent of the NHS app and NHS login. We want to enable good communication within clinicians. We need to be careful for resilience management, obviously enable healthcare analytics, have an eye on the environment and the impact that we have with all these millions of computers and hot server rooms everywhere, support and develop the workforce for the future, and then keep this all within cost and not bankrupt the organisation or the NHS as we go forward. Next one, Kev. Okay, so now I'm just going to jump onto system usability. So UHB, we're lucky in UHB. It's a strange brilliant job, because we employ a team of programmers and build an EPR ourselves. So this is a clinically led project. So clinicians are derived from all specialties across the wide organisation in which we work. And the digital leads are doctors, and even I still have 50% of my job plan in clinical practice, which means I have to use the systems myself. So there's leadership from exec level, and therefore a mandate across the organisation. And importantly, I think for this group, maybe things that would be helpful to share. So we've just completed the largest NHS secondary care EPR rollout. So 4 hospitals, 2,750 beds. So now serving 1 million outpatient appointments a year and 360,000 ED attendances per year. Next one, Kev, please. So this means that there's a lot of data generated out of the back of the systems, and and everybody on the call who've, will start to see this out of the back of their systems as well. So we now reported 67 million results from the systems last year. 440,000 imaging requests were made, 112,000 intraspecialty referrals, 120 million observations, 3 million prescriptions, 5 million inpatient note entries. So this is where the data that I'm talking about is generated, and this can really start to drive, innovation, research, and actually day-to-day running of health systems because of this huge generation of data. Next one, please. So in terms of usability and what systems we're talking about and what we're using, I think that quite a lot of EPR now starts to try and define rigid care pathways. And in my opinion and my experience, this just creates lots of workarounds. If there are lots of risks associated with workarounds, because you actually lose, well, you lose your audience, but you also lose your data. So I'm much more interested in systems which funnel practice rather than restricting clinicians to a single rail. So instead of you have to do it like this, to say, wait a minute, you're going way outside the bounds of what we would normally expect. Are you really sure about this? And so the idea of these kind of systems that are designed like this is that you avoid error rather than create reliance on a system or create workarounds. Next one, please, Kim. So of course, use is crucial. So it's all very well wanting to gather data for research, but we all know that clinicians will avoid putting in data that they don't think is helpful or just is too laborious to put in. So if we're going to gather data, we have to be sure that it's going to be used for direct clinical care and driving clinical decision support in the here and now and have immediate clinical consequence. These are 2 very big drivers for doctors, nurses and allied health professionals to add data into systems. But also, of course, then you can use the data for organisational awareness and understanding of your own processes within the organisation. Of course, most people on here will be converted to the idea that coded data is generally more useful than text, but with the new text mining tools, maybe we start to switch back and we can actually use lots of AI tools over the top to drag things out of text that we previously were hidden. Scanning is generally unhelpful, and hopefully most people have abandoned that now. Hardware and access is critical, and in most organisations of our size and busyness, you learn that the hard way. If you don't flood the place with really good computers and have fast Wi-Fi, then you're on a hiding to nothing before you've even started. So, for example, when we rolled out ward order comms across the organisation, it had to include every single bed and every single side room, because otherwise, you soon lost your users. Screens have to be the right size. You have to have the right kind of equipment as well. We've found over time that tablets aren't particularly helpful or well used, and people want interfaces like keyboards, and we start with voice recognition now, although of course in busy ward areas and so on, that's got its own set of complications. Next one, please. All right, so I just wanted to show you a couple of slides about changing behaviour. So in the organisation, we were interested that we'd done the NHS England thing about putting in a screening thing for venous thromboembolism. So when you come into the hospital, you can't admit somebody onto the system unless you've done your VTE screen. So that's all fine. So everybody gets that done. The trouble is the screen then suggests that you should give some anticoagulation to the patients who are at risk. And of course, the system doesn't do that for you because it's a dangerous drug and you have to be, you know, careful about who's getting it. So what we found was that some people just never did this. They just left this for somebody else to do. And if you interview the doctors who are avoiding doing this or only doing it less than 50% of the time, what they say is they're actually generally good doctors who are very well-meaning and careful, but they aren't really sure about prescribing this kind of dangerous drug, so they sort of just leave it to somebody else. But when you point out to them that this is a risk in itself, a risk of omission, and that, you know, it's a patient safety problem, then they individually convert their behaviour. And you can see the conversions there for these 3 individuals that were interviewed in this project. Next one, please. If you look over the whole of the project, all of these dots represent prescribers, and the dots are scattered all over the graph. So if they were all prescribing what the system said all of the time, all the dots would be at the bottom of the graph, but they're scattered everywhere. So this probably means that quite a lot of people are avoiding doing what the assessment or the system has requested they do. So after a lot of shenanigans about this, like educating people, sending people out, talking to people, talking to the users and understanding why they were doing what they were doing, we actually just made and we did change this graph, by the way. I'm not going to show you the whole story, but the dots start to go down the graph as you do all these various interventions. But then what we did was we locked the prescribing. So we said, right, okay, everybody else can carry on in the system. You can give the drugs that are prescribed. You can do your observations. You can do clinical noting, all the rest of it. But you cannot prescribe any more drugs until you've decided on the enoxaparin that the system is proposing. So you either have to delete it or you have to prescribe it. Next slide, please, Kev. So we made this change in the EPR, which luckily, you know, we're in a very privileged position of being able to control ourselves. And next slide, please. And then you can see all the dots go to the bottom. So this is just a kind of very good example of how you can actually completely change behaviour by making an actual change in the software. The interesting thing about this is, if you can go to the next slide, please, Kev. Oh no, this is going on something else, sorry. But the interesting thing about this is that you get loads of halo effects with this, because once you've started to make changes where people have to make decisions, oddly enough, if you look at the rest of the data, it moves into their other behaviours and they start making decisions about other things. So the number of proposals that are made in the system, so the system proposes oxygen for anybody who they detect the nurses have put on oxygen and so on. And those kind of proposals also start to be dealt with by the junior doctors alongside the change in the effective force change in the EPR. Okay, so just a couple of last slides then. So CCIOs in terms of the whole system. So by that I mean the ICS or the national kind of NHS itself. You know, what are our roles in there? So I think that, you know, one of the reasons for trying to put together forums like this is to start to think about interconnecting EPRs and how data flows across systems. And, you know, the shared care records and so on start to do this. Of course, at the moment, we don't really exchange data, if we're honest. We can do lots of look up and leave, but we don't poke data into each other's systems. If we were going to start to do things like that, we would have to be quite adherent to standards. And I think lots of us are now, you know, coming on board with NHS standards, but its conversation probably needs to be led by the clinical people like ourselves. Leveraging data use, of course, is important, and what we're all doing, and sharing projects and sharing data together will mean that those become more and more powerful. I just want to say something about digital first, because we hear about digital first a lot. I'm not sure that digital is always like sensible to be first. I think digital, when beneficial, is a good idea. Some things aren't better in digital, by the way, I think. So we just need to think about the lessons learned when we're talking about that. And then I think one of the things that might come out of these forums is the conversation about your sovereign organisation versus the system. And what happens when the two things are trying to do things that are subtly different or radically different, or in a different order, so you can't align things very easily. So last slide, please, Kev. So the last one is about data use for research. So important collaborations across the system now for data realization. And as everybody starts to be able to get their data out, I mean, we're collaborating with some of the big London hospitals now to triangulate studies and data, because we all start to be able to leverage these huge data lakes. Testing algorithms in real world data sets, I think, is very important. Industry push a lot of stuff onto us, you know, the latest AI thing that's going to solve everything to do with everything, but it hasn't been tested in real world data sets. And of course, across the East and West Midlands, we represent a very good mix of people. And, you know, often these AI tools have been developed in very narrow groups of people. We need to be mindful of that. And we've got some AI projects going on with the University of Birmingham. Be happy to share those in future meetings as well. And then we've set up a little research group within the hospital itself now, as a kind of quality assurance, or chasing our own series, our own datexes and so on within the hospital, and seeing in themes of those whether then we can start to deploy the digital systems to actually solve the problems that we repetitively have.